So why students go for MRCP? What exactly MRCP? Okay. So suppose there are so many students in India or globally in the respective countries, they are doing their UGs and post graduation. But those who are planning to move abroad, or they want their global career mobility, okay, or work outside India or their respective country, this could be one of the very good option for the future. Okay. And there are some basic misconception for some candidate, even some specialist doctor also, that why MRCP, why not other exam? Suppose if you are planning to move UK, so there are couple of options. If you are willing to pursue your career in medicine, there could be a pleb entry or it could be MRCP. So what could be the basic difference between pleb and so pleb is like just licensing exam. It will not give you any credentiality or any degree or any post graduation specialist. Okay. While MRCP is a qualified specialist degree, it gives you the acknowledgement that yes, you are a competitive doctor in field of medicine. Okay. And if you want to pursue your career for like as a ST3 level or ahead, if you want to go for a specialist course like we call CCT, okay. So this will be the mandatory route in UK. You have to complete this, all right. And so this is the basic. I mean, there are so many things, okay. So to road to the MRCP, so basically it consists three parts, correct? Part 1, part 2, and part 2 clinical. So if you see the part 1 has two written papers, okay, 100 question each, and it will be around 3 hours paper for one and 3 hours for part 1 second paper. So it will be total 6 hours of exam in a single day, correct? So this is also a very good challenge or very challenging things because to sit in exam for a straight 6 hours, you will get a break here for a while, but to sit in exam in a single day for 6 hours and compete for all the question, it needs a lot of practice. Okay, a lot of practice. I mean, you cannot practice for at least 15, 20 days or 1 month and you will go in the exam. If you are very intelligent and your stamina in the sitting exam with the pressure like this kind of exam is very high, then you will come out with flying colors in this exam. Otherwise, you will need proper practice at home for at least 3 to 6 months or for at least 1 month. You have to proper sit at home and give the mock test on there are a couple of website like past test. Okay, so you have to sit and you have to give the mock in a proper time manner. So you will get the idea that are you able to complete the exam paper or not? Because at the end you get fatigue out, and that's where everything starts fumbling. Simple question you do wrong, and your marks go down. Okay. It's not that you don't know the answer, but you know the answer. But at the end of the 6 hours, you are so fatigued, your mental uh, fatigue is so high that you don't pick up the correct answer in simple question, and that could be a disaster. Okay, so we have to follow the scheme, the routine, and the practice. Okay, same part two is the same. Okay, it will give you part two will give you depth of more like internal medicine. This question will be clinical based questions, okay, with clinical analysis and imaging questions will be there in part two. Part one, you will have very less imaging, most probably ECGs, okay. But part two, you will have some pictures of MRI, sometimes CT, sometimes X-rays, okay. You have to interpret images. There are almost 30 questions comes for image based in part two, but not in part one, okay. And then PACES. Okay, so PACES is one of the most challenging step in MRCP journey. Okay, it it needs so much dedication and so much of practice at bedside. Okay, it will give you in depth and believe me, truly, if you go with these PACES, it will give you so much of depth internal medicine knowledge, and that's how it is widely recognized globally. It will give open the way or doorstep to international centers. You will be recognized as a specialist internal medicine doctors. Okay, so these are the parts and the steps of the MRCP exam. Okay, we'll discuss this basis in another lecture. Today we will focus on part one. Okay, so this is the syllabus of part one. Okay, so it will be almost 15 to 17 specialties subjects. Okay, 1, 3, your 5, 8, 11, 14, and 17. Okay, so if you see, this is I have noted down from the MRCP website. Okay, so if you see the weightage system wise, like question which contain the maximum weightage. So one is your 25 questions, which is your clinical science. And after that, you see the 15 questions from pharmacology, 14 from cardiology, 14 from endocrine, gastroenterology, infectious disease, neurology, renal medicine, and respiratory medicine and rheumatology. All these are almost 10 subjects which are heavyweight. I mean, they contain so many weightage. And for MRCP 1, personally, I believe that this cardiology, neurology, and endocrinology is favorite of MRCP. Sometimes even in clinical science, they will ask you the clinical questions related to your cardiology, related to your clinical anatomy, clinical uh, neurology. So neurology is favorite, cardiology is more favorite of part one examination. They love to ask different questions of cardiology. Okay, but at the same times, all our other subjects also same weightage. Okay, so you have to pay attention to every questions, every subjects, and you need to make a proper strategy how to go because there are like students, and I have seen personally also that candidate they are preparing for 1 year, sometimes 2 years for part one, and when we ask them that when you are going to book your exam, they will say that still I'm not confident. I need some more time because there are some factors. One is lack of commitment, lack of strategy, and lack of mentorship. Okay. If you don't have these three commitment, these three strategies, believe me, I have seen personally many candidates, they prepare for years and they don't book exam. They have material, they have the question bank, they have so many books. Okay, they have copied the books, they have gone through the question bank, If I ask, so how many times have you gone? They are saying that, okay, I have completed past medicine 2 times. I have completed past test 1 time. Okay. But still they are not confident enough to book the exam. So for that, you need a proper commitment that no matter what happens, I need to read at least 6 to 8 hours per day. Okay. And that depends how basics, I mean, your basics is how many like in-depth basics are clear or not. Okay. So there are two strategy which I personally believe that most doctors do. One is 3 month strategy. Okay. So those students who have been previously exposed to the MRCP exam and curriculum, they have been looking for this syllabus, and then they make a decision that now I will go for exam and I will book my exam in next attempt and I will complete my syllabus in 3 months. Okay, so we'll say this is like a sprint, it's a marathon. Okay, because these 3 months and 17 subjects, not the one, two, 17 sub-subjects of internal medicine, you need to master at least to pass the exam. So it's not a small piece of cake. For that, you need very aggressive and high yield clusters and preparations. So if you want to go for this 3 month strategy, okay, so there will be a phase 1 which required high yield domination, like for at least for 6 weeks. Okay. And what you can do is that you can use your time very wisely, very meticulously, and very strategically. The big subjects like cardiology, okay. So cardiology, nephrology, respiratory, endocrine, neurology, and pharmacology. Okay, these are the all these subjects contain at least 15 questions each, 14 questions each. So weightage is quite good for these subjects. So you need to do at least 50 to 70 minimum, and if it is a good minimum 100 questions per day with understanding of explanation. Not just reading a question. Reading a question will only take for 3 hours or sometimes 4 hours. But you have to understand, analyze that what is the basic of that particular question and what is the basic of that particular topic which I am reading. So if the question comes from that topic, or suppose another question from the same topic, your basics are clear enough to crack that questions. So you have to read with strategically. Okay. And do not read big textbooks. Read the explanation of that questions. Okay. And specific those questions, like you have attempted and you got the answer wrong. So go for explanation and in-depth reading of that questions explanation. So you will remember it for future. And always when you are reading in a 3 month marathon kind of situation, always follow 1-4-7 rule. What is 1-4-7 rule is that suppose you read cardiology on day 1, you please do revise cardiology on day 4. That's how your memory will build up, and also revise on day 7. So this is 1-4-7 rule, which is very practiced and proven in every field. That if you want to get success with like strategically and planning, if you follow this rule 1-4-7, you read first day, you repeat on the fourth day, and you also repeat on the seventh day. Your memory, long-term memory will be good, and you will have a better idea and understanding of particular questions. Okay. Now what will be the phase 2? So it will be the niche science. Okay. So week 7 to 10, the biggest subject, clinical science. which involves your pharmacology, genetics, statistics, clinical neuroanatomy, neurophysiology, biochemistry, clinical biochemistry. Okay. So these are the easy marks, but are very confusing and like one line questions. So you need to read it multiple times to mug up or to understand in depth so you don't forget because believe me, these clinical science questions are like a yes or no question. So it depends if your reading was like with concentration or not. Okay, if you are able to remember the question and the funda or the particular answer, like the question comes Marfan syndrome. Okay, so what is the genetic of Marfan syndrome? What is the gene which can lead to Marfan syndrome? What is the most common cardiac complication which happens in Marfan syndrome? What are the most common respiratory complication which patient usually in a clinical life present with? So these are the straight answers. But if you remember, you will go good. If no, then you will go zero. Okay, so you need to have very focused reading in these subjects. Okay, so that's how you can go for phase two. And then phase three is your week 11 to 13. You go for mock exam. Okay, you discuss with your mentor, you study with your partner, and each day you attempt one mock. That will build your confidence and that will actually give you idea that where you are standing and how much is your preparation. Okay, so here you have to go for basic inheritance pattern. All you have to remember, there are so many factors and the topics and the charts which you have to remember clearly, like some drugs, mechanism of action, genetics. You have to remember autosomal dominant, autosomal recessive. What is the mode of inheritance? Okay, some drugs complications, some indications of particular subjects, like indication of treatment of rheumatoid arthritis, indication of giving defibrillation, in which kind of the condition you can give defibrillator therapy. Okay, what are the contraindication of medication, like suppose amiodarone? What are the clear-cut contraindication? So they will give you one clinical question that this patient is like 60-year-old patient presented with this, he had this condition, and his BP is this, his heart rate is 150 with fast ventricular rate, ECG shows AF, what he will do. So you need to have a basic idea that what is the basic treatment step modality of management of AF, what is the indication of amiodarone, when you can give, when you cannot give. So these you have to be very careful because, for example, hypokalemia and ECG. So there are two, three things which usually student get confusing in the exam, like J wave, U wave, hypothermia, hypokalemia, which one is which. So if you will mess up with this kind of question in exam, no one will give a guarantee to pass. And for that, you have to be very careful about your study preparation, that what you are reading, concentrating you are while you are reading the questions and understanding the subjects. Okay. Then that was the strategy one. Now strategy two, which is 6 months. So some students are like they know, okay, I need more time to clear my basics. Okay. And then once I will clear my basics and then I will go. Okay. So what could be strategy for this is, so first 3 months, which is a foundation time or rotation, systemic rotation. You dedicate every 2 weeks to one major specialty, like suppose cardiology, you go for week one, week two, you go for neurology complete, week three, you go for complete suppose rheumatology. Week 4, you go for pharmacology, and in between every once you give 1 day to revision. Suppose you have read cardiology on 7 day before you start another subject, neurology, you give 1 day rest, and that 1 day you just revise the cardiology what you have read in 7 days. Okay, then repeat. So this is the strategy for at least every 2 weeks. You can use the question banks, past medicine, past tests, or supplements. Okay. And there are a couple of books like Notes and Notes. If you have time, there is one books, Oxford Medicine. Very good book. One is McLeod's Internal Medicine book. MRCP follow clinical strategies and clinical examination patterns and everything very likely similar to this book and Oxford Medicine book. These are past medicine and past tests are also very good. The questions, the theories are very good. Okay. Then phase two. Okay. So now in phase two, you have to integrate your previous knowledge and you have to go for clinical science. You go for small subjects like psychiatry, ophthalmology, dermatology. Okay. And then you revise them quickly. Okay. So this will cover your at least first 4 to 5 months. And then last month, you go for speed again, marathon mode. Okay, repeat all the question banks. From the fifth month, I would suggest that you start to attempt question paper at least once every other day. Okay, this will give you a idea that where you are after 4 months of preparation and how much you need time to specific subjects. Suppose you are weak in neurology. Some candidates are weak in genetics, some candidates are weak in clinical science. So everyone has some strong factors and weak factors. So you will require that to assess for your individual level, and then you will have idea that what you need to go for, what which subject you need to give more time. Okay, and there are question paper for 3 hours, like 100 questions, and then 100 question for 3 hours. So when you are attempting this question, you at least try to finish in 2.5 hours or 2 hours and 45 minute maximum. Why? Because in real time, real exam, you will have so much of pressure, and at least you need 15 to 30 minutes to revise your all the answer that sometimes you have passed that question and you thought that I will come again and then I will think of this question and I will mark it. But by the time the you finish the paper, time is kicking. Okay, so you need at least 15-30 minutes a spare to revise your all the answer booklet. That any question you have marked double, any question you have missed, or suppose the question 98 answer you have mistakenly click on 97. So even though you think that your answer was right, but you placed on the 97. So please do not do this kind of the mistakes. And these mistakes only happens when you are anxious. And anxiety comes when you are underprepared. Okay. So for that you need to prepare very good, a good commitment, a good execution plan, and a good mentorship and a serious group of like-minded students who are preparing with you. Okay, so this is the basic idea for the part one. And if you follow either of the strategy, 3 to 6 months are enough to crack part one. Believe me, it's more than enough to crack part one. But first, you analyze yourself, okay, and you see where you are standing, how much time you require for preparation and understanding of the subjects, and then accordingly you take a call, okay, and then you can go ahead. Okay, and there are couple of things like registration and the exam venue and all these things. I think all are aware about this, so we will skip this. Okay. So we'll do a little bit of cardiology question. You have any questions? Anyone?
No, sir, we won't have any questions.
Okay.
Sir, regarding
So
the registration and like once the process, if you can like, explain it up, like I'm not been aware about like how to like register for it, and once we can give in a year how many times. Like for example, if I start right away with you for 3 months of its strategy, then when I have to be like register and like what is the total amount like I have to give for the registration for a part 1 and the
so part one, there are some criteria. Suppose for part one, after your UG, you need a 12-month of complete internship experience. After your degree, I mean your MBBS, you need a 12 months of clinical experience. And after that, you are eligible for that to apply for part one. Okay, so you can go to the RCP, Royal College of Physician RCP website. You make your account. Okay. Once you register with your account, you need to fulfill some personal details and they will ask you to upload the document. The document will be your internship certificate and your degree. The degree should be notarized with international validation. So there are some notary which are like locally valid, or some notaries are validate internationally. So you have to go to some notary place and you have to like attestation of your degree document which are recognized, and then you upload them. Once you upload, then they will give you within almost, if I'm not wrong, 7 to 10 working days. They will analyze your document and then they will give you go ahead. Then the portal will open in your account. Once you are done with your documentation and upload, you can go to the exam history in your account. Okay. So once you give, there is no exam history, and then you see upcoming exam. So here you will see MRCP part one date, part two, and all these things. Okay. So like there are three diets, I think. One is your December diet, then March, May, and then September. Okay. So suppose if you are preparing like fifth, today is the like May, and if you are willing for September, the window period will open in June, almost 2 to 3 months before. So you have to be very like aware that when the window will open. Okay, exact date I am not sure. I will share in the group. Okay, that when the window will open. So you can book the exam, and there are a certain amount of the fee. I think, if I'm not wrong, it was 680 pound. Think now it is around 780 or 760 something pound for part one. So if you are confident enough, because this is a good amount of money, so once you are confident enough with your preparation, okay, then you book the exam, because once you book the exam, unless there is no very strong reason which fits into their criteria for refund, they will not give you any refund or cancel your attempt. It will mark as an attempt. Okay, and you have 6 attempts. Initially, it was time duration, but in 2023 they have changed the guidelines and they have made the attempts maximum attempts for part one, two, and also the PACES. If I'm not wrong, each part they have six attempts. So unfortunately, if you don't clear then 6 attempts, then you will not be able to again to sit in the exam. The door will be closed. So you need to be very sure, okay, before you apply. I will share the link in the group, and also I will share the dates of the exam. Okay.
yes, sir. Thank you.
Uh, all right, all right. So we'll just do little bit of questions for cardiology. So read the question, then 1 minute, and then we'll discuss this.
Continue. Yes, sir. Please proceed.
Okay. So uh, if you see, read here. So you'll see there is a young patient. Okay, athlete. Okay, and he has a he rushed to the emergency department with 30-minute history of rapid palpitation and lightheadedness. Heart rate was around 190, BP was normal, and ECG shows narrow complex tachycardia. Okay, and he mentioned that having spatial baseline ECG that his GP previously described was showing that there was a short PR interval. Okay. And once the doctor in the ER did the carotid sinus massage, the tachycardia terminates and the resting ECG was done. When the resting ECG was done, so from that, which of the following features in the resting ECG specifically indicates that the presence of a bundle of Kent? So here, which condition we are discussing here?
Sorry, sir. I am not aware about it. Like bundle of Kent.
Okay, so here we are discussing a specific condition we call WPW syndrome, Wolff Parkinson White syndrome. Okay, so once like Wolff Parkinson White, okay, so what will be the answer here? The answer will be B. Okay, the presence of slurred upstroke R wave. So for giving to give answer of this question, you need to understand the like why I choose this question, because this is not an easy question. This is a moderate level question. This is also not difficult. And this kind of the question usually comes in MRCP part 1. Okay. Because they will ask you that what kind of the findings. So basically they are asking the criteria. What they are asking is they are asking of the ECG criteria which confirm the diagnosis of WPW syndrome. Okay. So here the slurred upstroke of R wave is like classical delta wave. Okay. I will discuss this. Why? Okay. So let me show you the. So suppose this is your heart. Okay. Correct. This is your SA node,
Yes.
and the current will go from here to AV node, and then here, and then go from Purkinje fibers and bundle of His. Correct. So these are the normal physiology of current which goes from SA node to AV node, bundle of His, and then Purkinje fibers. Now, uh, we remember in a simple way. So what actually happens in WPW? So WPW has this extra current. So this is a normal current we call gate A. Okay, remember as a gate A. So in normal, all the individuals current will go from gate A, then it goes to the bundle of His and then Purkinje fibers. But what happens in WPW? That is a extra current, okay, which go from the gate B back door. Okay, so usually if the current will go from here, there will be a little bit delay, 0.1 second delay. And if you see the ECG, this is the normal ECG, this is the P wave, and this is the little bit of delay, PR interval. And then you will have upstroke of ventricular contraction. Okay, this QRS complex. But what happened in WPW, that this current from here, it will also go from here. So here it will take a delay, but once the current will go from the extra backdoor channel, it will be sudden, like sudden wave, extra current, which does not give a delay, and patient will have a sudden upstroke. Okay, so that's why the premature contraction of the ventricles, which gives this upstroke of R wave, and we call this a delta wave. Okay, understood? Okay, so
Yes, sir.
and what are the ECG triad? So the PR interval, because usually when you see this is a P wave, this is a then QRS. This is a P QRS. These are the PR interval. So normally there will be a delay, but because of the extra current, the PR interval will be less. So usually it is 0.12 second or 120 millisecond. It will be less than 120 milliseconds. Okay, because electricity gets faster to ventricles. So and then delta wave. This upstroke will create like this slurred. Okay, delta wave. Okay, slur at the start of the QRS complex. This is initial ventricular activation. Okay, this is because of extra current, because of bundle of Kent, and this extra current, which what we call bundle of Kent. And how does bundle of Kent recognize in ECG? This early excitation of the ventricles. Okay. So what are the criteria? If you can remember that short PR interval is one of the criteria, because if you understand the physiology, once you have understand what is the physiology, then you will never forget what are the criteria. Then you don't need to mug up this criteria. Okay, because of these, the PR interval will be short. There will be slurred R wave, which we call delta wave, and because of these delta waves, upstroke R wave or slurred, the QRS complex will be wide. So these are the criteria for WPHW syndrome. So there can be a question you may ask in the MRCP exam, that what are the criteria given below. You have to choose which is not. So if you remember this question, it will be very easy for you. Okay, so you have to understand the basic of the question, what they are asking, and if you are done with your basics, even if the question comes in another way, you will crack it. Okay, and also you have to since we are discussing this WPW, so what are the treatment and what are the red flag signs you need to remember? Okay, suppose this patient, like this previous patient, comes with tachycardia. Okay, they may ask you which kind of the tachycardia is most common in WPW. So this is AVRT, atrioventricular reentrant tachycardia. Okay, this is very common. Okay, and which is the most lethal one is that if the patient with WPW, if it develops AF, because at times in AF, patient present with ER, usually if we are not aware of the history and patient is not diagnosed, usually we give a calcium channel blocker, okay, like amiodarone or Delzem, this kind of the medication you give for AF. But if you are not aware and if you don't see ECG and you don't recognize, you may cause disaster. Why? Because what happens when you give calcium channel blocker? So calcium channel blocker work here. Let me just pick the another one. Okay. So calcium channel blocker work here. It will decrease current from here to here. So patient has presented in WPW tachycardia because of this way. The current is going from here. That's why he has a firing here. And you are giving the medication which are delaying the action here. But this will be continue. So once you will give any digoxin or calcium channel blocker, it will reduce this work of action of this gate, but the gate B. So here there will be no action. So more the current will go here. So patient will have worsen of the tachycardia, and it will worsen the arrhythmia, and patient will end with cardiac arrest. Okay, so you need to understand where you need to give the medication in WPW syndrome, we don't give which kind of the medication, which kind of the medication are contraindicated. Okay, and then the definitive management is radio frequency catheter ablation. So these are the way you can understand the question. Okay, you read the basics and then you go for it. Okay, so let's go for second question. Again, I think the same question. Okay, so we can do this one more question. You can read the question and then if you wish to answer, you can answer and then we can go.
The B option, if I think so.
So you are thinking of
B
soft
option.
first heart sound. And why is it?
Sir, other the patient is having the syncope history. So definitely the pumping, the heart is one which has been pumping the blood.
Hmm,
So sir, as far as I remember, I watched some of the lectures of Marwa sir. There he like discussed of like, exact to be, behind it the concept I don't remember. The only thing which I remember this is the point. Like
okay.
might be
So
I may
here,
confused or something.
no worries, no worries. So here there is a 78-year-old patient present with syncope. You did the ECG and ECG shows complete heart block. Okay. There is an intermittent P wave activity which is visualized on the ECG but no relation with the QRS. So this line is the criteria for complete heart block. Correct? So
Okay,
now,
sir.
which one of the following physical signs consistent with the diagnosis? So what are the things you see apart from this
Heart
option
rate.
in the uh, complete heart block?
Okay,
Okay, so we'll see what happens actually in the complete heart block. So once there is a complete heart block, there will be slow rate. Okay, so before that, let's just discuss a little bit about complete heart block. So complete heart block, okay, so heart block. Heart block has three types, yes? Type 1, type 2, and type 3. In type 2, you have 2A and 2B, correct?
okay, sir.
So all the things we remember with the ECG, okay, so this is P wave, Q, your R, S, and your T wave. Okay. So now, just for the simple thing, remember this P as a wife. Okay. And this QRS as husband. Okay.
Okay, sir.
Okay. So what
Okay,
happens? So in normal happy family, P is aligned with QRS. So everything is good. Everything is happy. Okay. What
okay, sir.
happens in first degree? So in the first degree, what happens that the P wave, P wave is waiting for the QRS. I mean, there will be, and the husband, the QRS comes home every night but comes late. It will come. So what happens in first here? So this is P waiting for QRS. Okay. QRS will come but late. Okay. So there will be
Okay,
PR prolongation. Okay. But there
okay,
is no miss bit. Okay. Then what
okay,
happens in 2A? 2A will be, we call is Wenck phenomena.
Weekend back.
Wenck phenomena. Type 2A. Okay. Now what happens here? The P wave. Okay. So the wife is waiting at home and the husband comes. Okay. One day he comes little bit late. Okay. This is T wave. This is, and then again this P wave. Then second day is come little bit more late. Okay.
Okay.
So there will be gradual prolongation of PR interval. Correct.
Okay, sir.
And there will be type 2B. Okay. So what happens in type 2B? This is the P wave, QRS, and then T. What happens here? There will be, he is coming late, and sometimes doesn't come. So here you will see the misbeat. Here, fixed prolong, PR prolongation. Here,
The
gradual
graduate.
increase.
So,
Here, there will be
mix
prolongation
it.
of PR interval with misbeat. Okay.
Okay, sir.
So, and there is type 3. There is no relation. He is not
Okay.
talking to husband, and husband is not talking to wife. There is no relation between P and QR. He is working by himself. She is working by himself. So sometimes you see the P wave. Sometimes only see QRS. There is no relation here. So remember, if there is a like communication gap, like here, he is forgetting to come at home. So here you will need one communicator. So who is the communicator in medicine here? Pacemaker.
Okay.
So which condition you need pacemaker? Type 2B
Sir,
and type 3 you need pacemaker.
yes.
Correct? This way you
Yes, sir.
remember. Now, what happens in complete heart block? So complete heart block, there will be no relation. Okay, the patient will have bradycardia. The heart rate will be slow. So once the heart rate will be slow, there will be compensatory increase in the stroke volume. The stroke volume will be increased, which is a sum of cardiac output. Okay. And
Yes,
then
sir.
once the stroke volume will increase, there will be large volume pulse. Stroke volume will increase, patient will have large volume pulse, and there will be a systolic murmur, which is not a like a pathognomic murmur, it is a flow murmur because of high volume flow. Okay. And
Okay, sir.
there will be irregular A wave. If you see the clinically at bedside, the JVP, you will see the Canon A waves. Okay. And then the irregularity of the Canon A waves distinguish between complete heart block and junctional rhythm. Okay.
Okay.
So this way you remember, if you remember
Hard
the
block.
basics of the heart blocks, you will understand that what could be the answer and how to give the answer of particular questions. Okay.
Yes, sir.
We'll do one more last question and then we can wind up. Okay.
Yes, sir. A 40-year-old man present with a cardiac sounding chest pain. So please tell.
So what could be the answer?
Sir, I expected of like calcium channel blocker diazepam.
Diazepam is not a calcium channel blocker, it is a diltiazem.
Diltiazem. Oh my God. Yes, the diazepam is definitely that confused. The verapamil diltiazem.
Okay. So you
Yes,
cannot afford to miss this kind of confusion. Okay.
yes, sir. Yes, sir. Yes, sir. It's by
So
mistake.
this is ecosprin. This is the beta blocker.
Beta blocker, sir.
Ecosprin is a COX
Anticoagulant.
inhibitor. Correct.
Possible.
This is the
Yes,
beta
sir.
blocker. Diazepam is one of the
Antipsychotic.
benzodiazepines.
Yes, sir.
Okay, atenolol is your again your beta blocker,
Beta
and this
blocker,
is
isosorbide
isosorbide
mononitrate.
mononitrate,
Yes,
which is nitrate group. Okay,
yes, sir.
so what happens? So this is the question of vasospasm. So Prince metal angina or variant angina. So what
Okay,
happens here? So patient will have a rest pain, chest pain at rest, usually at night or early morning. And if you see the ECG at particular time, patient will have a transient ST elevation.
okay,
Okay. But if you see the coronaries, if you go for the
okay,
CAG and everything, the coronaries will be completely normal. Why, what
okay,
happens? Because of the focal coronary artery spasm.
okay.
Okay. Because of the stress and the hormonal factor, the artery goes under the spasm. It is not because of the atherosclerosis,
Yes, sir.
not any plaque. Okay. So
Okay.
this vasospasm, how we will treat with calcium channel blocker.
Yes, sir.
One
Good
is
to
your
hear.
diltiazem and amlodipine, or long-acting nitrates like beta blocker. Relatively, uh,
Beta blockers contraindicated.
yes. Which are the contraindicated? If the patient has any asthma, any condition
Mm.
like this, and
Bronco.
long-acting one are contraindicated. Short-acting we can give.
Okay.
Okay. And then if you give any beta 2 blocker which do vasodilatation, and if you go the unopposed alpha vasoconstriction medication which can lead to worsen of the spasm. Okay. So you have to be very sure that what things you are giving. Okay. So here
Yes,
the
sir.
answer will
I
be
could solve it.
nitrates.
One.
Isosorbate nitrate. Okay. So
Yes,
this way
sir.
you have to remember because calcium channel blocker and the nitrate, if the options are given, so isosorbate nitrate is the only vasodilator. Okay. Why? How it acts? Because it can lead to the relaxation of the smooth muscle by releasing the nitric oxide.
Okay.
Okay. So this is the vessel. It will release the nitric oxide, and nitric oxide
Will relax
will
the phone.
like there will be a, if you remember the biochemistry, guanyl cyclase and the cyclic AMP, and
Yes, sir.
then light chain, and it will lead to vasodilatation. Okay, so
Yes,
this
sir.
will reverse the coronary artery spasm. Okay, so if you see in clinical practice, calcium channel blocker is the first line treatment.
Yes, sir.
Okay, but if it is not listed, okay, if it is
Yes,
not
sir.
listed, because here this is the COX inhibitor, this is beta blocker, these are the sedatives,
Beta
again
blocker.
beta blocker, and these are nitrates. Calcium channel blocker is not in the option. So if you see in the clinical
Active.
scenario or the scenario is given this, you have to look for the calcium channel blocker, which is the first option for the treatment. If the
Okay.
option is not given, then you can go for the nitrates.
Nitrate.
Correct?
Yes, sir. Sir, I have
All
a
right.
doubt with you.
Mhm.
Sir, when you will like starting for the classes, like
Most probably from the June 20, oh, sorry, May 20 will start. We had a word, but I think you were busy and I was also busy. So from this 20 May and regular batch from the 1st June we can start. Okay,
okay,
which will we will do like every Saturday, Sunday, or thrice a week class, and we will cover the maximum topic. We'll do a 3 or 4 hour class, and we'll try to cover maximum for concept of the medicine,
yes, sir.
which
Sir,
required for part one.
yes, sir. So just have a request with you. Like, for example, if you're taking classes now for 3 hours or 4 hours continuous, like it will be according to like Indian standard times, no, like in the evening, basically.
Yes, 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 yes.
Yes, sir.
It will be according to the IST time, or if we have some Sunday off, then we can
Yes,
go for
sir.
day.
Sunday, though, I can be the one with the whole day with you.
Okay, okay, okay.
And
So
the
we'll.
request, like, if you could, like, when you start the classes, sir, you could make a notes of it. Like, for example, whatever the notes that you have with yourself during your preparation are. For example, sir, the notes and notes, as you have suggested me, I have like downloaded the book, but the content is too much now. Like every time, even the being one to be very fresher in this field, it's very tough to memorize also, and to get segregate out data which is very important or ultra important, because everything we
Hmm.
can't remember and
No
carry out
worries.
on a day
What
of exam.
we can try to ease these subjects because there are if you'll go by subjects, if you read a book 2 3 times, which will I'm sure will take time.
Yes, sir.
So we have some strategy and we'll go according to this. There
Yes,
are
sir.
some core concept. If you will follow the core concept and understand the basic, I think you will not need to read all the big books.
Yes,
Okay.
sir.
Okay. So we'll follow some strategy.
Yes, sir.
Okay.
Yes, sir. Sure. Sir,